Over to you, Syed.
Hi, good afternoon, and welcome to my today's lecture. I will talk about spinal imaging. So spinal imaging is a very interesting and very easy thing. So most of you knows already. So we'll just discuss it. No conflict of interest. Okay, my lecture outline, I will discuss about some basic MR sequences, which we should have knowledge. Then MR anatomy, which is important. Then the most important thing, we'll discuss about the number disk nomenclature, how to count the disk and how to report the disk. Then we'll talk mainly about degenerative disease, then also a few cases about infection and the differential diagnosis of vertebral collapse, how to deal with that, and some important cases. So back pain is quite common, and MRI we are doing a lot. MRI is the gold standard, and everybody has, most of the clinicians, they have good knowledge about MRI spine. So that's why I thought to discuss MRI spine. So those who are in the early phase of the MRI learning, this lecture will be good for them. X-ray is still good, CT scan and MRI is the method of choice, but we should not neglect X-rays and CT scan. For the fracture, still CT scan is fantastic. X-ray sometime in follow-up cases, in the post-op cases, alignment cases, X-ray still we should do. We should not neglect any other modality because X-rays cost nothing and sometimes very helpful. CT is for the fracture, is still for fracture classification, CT scan the best. MRI is the gold standard because we can see the marrow. There is no other modality which can tell about the marrow of the vertebral body spine and the nerve roots. So no doubt, MRI is the best. Regarding our indications, so all the short duration low back pain, localized pain, we should not go for the MRI. Those who have low back pain with radiculopathy, going to the legs, thigh, radiculopathy, and increasing in pain, and that needs maybe surgery, that patient have to go for surgery. And the symptom of central arteries, claudications, and axial pain more than 3 months, not responding with the not responding with any treatment. These should have to take for the MRI. And sometimes severe pain generator for proper management, and other causes like tumor infection, there are other indications. There are a lot of criteria of the indications. I will not go in detail. Okay, technique. Most of the center all over the world, we do one T1 without Facet. So T1 weighted. This is the one we do always, sagittal and axial images. So what is the purpose? So T1, this is my first take-home message. Normally people, they just go to see the T2 because T2 are a little bit black and white and disc better seen. So they just see the T2 and the report. But we should not neglect the T1 because this is the what we bone marrow see in T1. So just take home message number 1. The vertebral body B should be brighter B than the disc. That is the most important. Normal marrow, anybody who is more than 20-25 of age, most of after that 25, our whole body, most spine converted to yellow marrow. So in that case, the T1 sequence, the vertebral body should be brighter than the disc. And suppose disc has some degeneration, some problem, then we can see by the muscle, paraspinal muscles. So this is my rule number 1. So if you take one message from my lecture, from first slide, this is this. Vertebral body in T1 is brighter than the disc. This one I will repeat later on also because this I like it. Because by this, I will tell you what are the importance. Okay, T2 weighted, we identify by the CSF. CSF is bright and T1, the CSF is dark. And steer sequence, everything is dark except fluid or edema. So you can see here fat is bright and fluid is bright. So this is T2. Here the fat is bright and T1 is fluid is dark. This is T1. And here's a steer, which is suppress everything, very nice for the fat set. So this is the best fat set image to detect any pathology. We call it steer, STIR, steer sequence. And you can see the vertebral body is dark, fat is dark, only CSF is bright, or any other pathology will be bright. So that is very nice to have steer sequence. So these are sagittal. We are doing axial again, T2 axial. So this is because CSF is bright. So this is T2, and we are doing axial T1 also. Some center in trauma cases, they add gradient. That is good for the catch the hemorrhage, and because that causes blooming artifact. So gradient are required. And sometime in post-op cases, we need to do post-contrast, or if you're suspecting osteomyelitis, some disinfection. Infection cases, we are adding the post-contrast. Post-contrast, again, we are doing in the T1 fat set. So from my first slide, just remember again, rule number 1, the T1, the vertebral body should be brighter than the disc. A little bit of anatomy. So this is the T2 weighted because CSF is bright. So this is T2 weighted sequence, and fat is also bright. So T2 weighted sequence. And this is the vertebral body. This is the disc. And here you can count like this is the L5. I will show you how to count sometime difficult. So this is L5, this is S1, this is L4. And these are the posterior element. In the posterior element, we have neural spine. This is the lamina. These are the facet joint here. Again, this is the pedicle transverse process. So same thing in the axial images. These are the lamina, neural spine. These are the facet joint here. And this is the parasagittal spine where we can see the neural filament. Normal neural filament are like a keyhole. So this is like a keyhole. So this is the exiting nerve roots, this one, and there's a small hair vessels. Cervical, the lumbar, almost same thing. Only thing here in cervical, there's one extra joint, which is uncinate process, uncovertebral joint. That causes osteoarthritis this area. This is the uncinate process and the uncovertebral joint. This cervical spine, again, where there is a spinal cord and there is a ventral and dorsal roots, and this is the neural foramen. And this is the spinal cord. You can see most of cervical and lumbar is almost same. Little bit of difference I will tell you in my further things. So now again, when we do MRI, this is it comes like this, from right to left we go like this. So here these are again, this is because CSF is bright. Fat is bright, so this is T2 weighted sequence, and this is the vertebral body. This is the disc. So this is L5, S1, S2. So L5, L4, and here you can see there is an intrade defect. These are smaller nodes, small SCHMORL, Schmerz nodes. So there are multiple Schmerz nodes here. So there is another entity when the vertebral body, more than 4 consecutive vertebral body have Schmerz node, we call it Tumorous Disease. That causes dorsal kyphosis. Okay, so this we'll discuss later on. We have some cases. So again, this is the end of the spinal cord. These are the nerve roots, and this is the ligamentum flavum here. If we go a little bit sagittal, then better see. So these are sagittal ligamentum flavum. So ligamentum flavum, normal ligamentum flavum is basically flat. If it becomes convex, it is abnormal. So more than another thing is that some people say more than 3 millimeter, but in some people within 3 millimeter we are normal. So if it is flat, that is normal. If it is convex, it is hypertrophied. Ligamentum flavum. And these are the axial images. So we can see these are the pedicle. This is psoas muscle. This is the paraspinal muscles. This is the important facet joint. This is the facet joint. And you can see here, this is the ligamentum flavum. This is the ligamentum flavum. So when it is this lining is flat, it's normal. When it is convex, like this, too much convex, that is abnormal. Sometimes bilateral ligamental hypertrophy that can cause some compression of the overthecal sac or ligament or canal stenosis. Okay. So again, back to the normal marrow. We will discuss about marrow signal. How to know abnormal and normal. So this is 1.5 Tesla. This is 3 Tesla. And this is 3 Tesla cervical spine. So as I told you, my spine rule number 1, the vertebral body should be brighter than the disc in T1. So this is normal marrow. This is in 3 Tesla, it slightly comes dark, but still vertebral body is brighter than the disc. So still it is okay. And sometimes 3 Tesla better to compare with the muscles. So vertebral body should be better than the muscle. Okay, check here. So this is abnormal marrow. This is T1 weighted sequence because the fat is bright. CSF is dark, so it's T1. And see the marrow. The marrow is, we can say, darker than darker than the muscles or disc. So this is abnormal marrow. And see the steer sequence, bright, just abnormal. So this is case of diffuse multiple myeloma. So if you have knowledge about this, so you can catch multiple myeloma, which is a serious condition. So whenever I found a T1, the marrow is dark, I just say dark marrow on T1, please correlate with the lab finding. It's very simple. They can do some lab test and they will know whether the patient has some anemia, other causes. There are some physiological causes and pathological causes. So we should also know anybody who is smoker, the marrow can be abnormal. Who is 200 kilo plus, abnormal marrow, can be abnormal marrow. On chemotherapy, there are so many causes of the normal, and there's the physiological and pathological conditions. But better to mention, so to save ourselves. So I just mentioned the in T1 shows the dark marrow signal. Please correlate with the lab findings. Lab findings, like they have, they can manage by lab, like leukocytosis. They have not leukocytosis, anemia. This can cause the abnormal marrow. Another case is anorexia nervosa. They have also abnormal marrow signal. Those who are not eating at all. Okay, so here in some cases, so this is a 50 years old man, and you can see the spine. This is T1 because CSF is dark, and you can see there is a yellow marrow here, but remaining there are dark marrow. So these are the red marrow in a 50 years old person. So these are reconverted. So anytime when body need more because of some conditions like sickle cell anemia, so many other conditions, the red marrow can be reconverted because of some other, so many conditions. So we should mention that red marrow reconversion is seen. Here we should have knowledge about spondylolisthesis. There is one orthopedist doctor's name was Meyerdings. So we describe this method according to Meyerdings method. So what is the Meyerdings method? So Meyerdings method for the spondylolisthesis, he draw a line from the end plate, then one line 90 degree to this at the corner of the end plate. So the previous vertebral body should be at this area, It should not cross. In fact, it should be 1 millimeter below this line. That is normal. If it is touch this line, across this line is abnormal. So if it is when 25%, grade 1, 50%, grade 2, 75%, grade 3 total is grade 4. So this is Meyerdings method, grade 1, grade 2, grade 3. And we should always go from base to up, not up to down, because the lower is stable segments. So we have to always go from like for L5, S1, we have to go from L5. For L4, L5, we have to go from L4. So this is the Meyerdings method of spondylolisthesis, forward displacement. There are many causes. Some are congenital, ischemic, degenerative. Like here in this case, the facet joint is abnormal. So normally there should be no fluid in the facet joint. There is an article where it says 2.5 millimeter fluid. Like this means I want to say thickness is a sign of instability. I have done around 50 patients, and I found that even 1.7 millimeter fluid in the facet joint can cause instability. I have not published this article, but I found 1.7 with instability. So these are degenerative causes of instability. Degenerative normally is grade 1, not so severe. So most of the time when there's a grade 2, grade 3 is most likely pars defect, spondylolisthesis. Another problem you will face sometime because of lumbar vertebra position, sometimes goes up, goes down. We call it sacralization and lumbarization. So how to count the lumbar spine? There are so many methods. Again, I have done one research on it. Like we go by the piriformis muscle level, which is S2. Then we go by the renal vein level. We go with the ligament level, so many levels. But the best method, which I like, and also the orthopedics people like, is that they touch the posterior iliac crest. So go to the posterior iliac crest, and corresponding end plate will be L4, L5. So this is why this is best, because when they operate, they go by this method. This is L4, and this is the L5. So when the orthopedics, our colleague, when they operate, they go by this method. So they are following this method, so we should also follow this method. Even suppose some extra, something like that, that will be good for the patient. Otherwise, they will do some wrong level surgery. So I go with this. We go to the iliac crest, posterior iliac crest, and corresponding end plate that will be the L4, L5. That is the ideal, according to me. I like this. I do like this for the counting of the vertebra. Okay, so another problem is, that spine is reported by the radiologists, neuroradiologists, so many radiologists, orthomanic radiologists, and sometimes they speak very different language. So till now, I think 2-3 conferences happened by this group, by neuroradiologists and so many associations. They make it that they said that better to speak a common language, and they prescribe that I'm going to tell you that we should speak common words, so that will be good for everybody, and they should understand what we are talking. So okay, so in this, like here, there's a disc going infraredly. We call it disc extrusion. That I will tell you why. So we should not say herniation every case like that, because in MRI we have to describe whether this is protrusion, extrusion, sequestration, disc bulge is what. So according to that nomenclature, so this is the normal vertebra, and normally disc is should not cross this end plate margin, this margin of the vertebral body. If it is crossed more than 2 millimeters, some book says 3 millimeters, cross the end of the vertebra margin, that is a diffuse disc bulge. So like here, this is the vertebral body margin, and this is the disc which is crossed all around. So this is diffuse disc bulge, and this thickness is more than 2 millimeters, should be diffuse disc bulge, which can say diffuse disc bulge if it is extending more than 180 degree. So again, if the disc extend the vertebral body margin more than 2 millimeter, more than 80 degree, it is called a diffuse disc bulge. If it is limited to less than 90, we call it disc protrusion, or focal disc bulge is disc protrusion. And if it's asymmetrical, we call it asymmetrical diffuse disc bulge. Like here, it is only extending on one side, asymmetrical diffuse disc bulge. Okay, again, disc protrusion. What is disc protrusion? The disc protrusion basically where the base is more, height is less, that is disc protrusion. When the height is more, the base is small, that is a disc extrusion. Extrusion can go up or down. And when it is separated, we call it sequestration. And when it is the base is more, height is less, we call it protrusion. So we should speak according to that. If there is a disc which has height is less and base is more, so we call it disc protrusion. Then when height is more, base is small, we call it extrusion. And extrusion can go cross the end plate. When any disc goes and crossing the end plate, that is a disc extrusion. And when it's separated, we call it disc sequestration. So we'll show you many cases, so that we should and another thing is that we should also speak where is the disc protrusion is. So this is, we call it central or post central, whatever, but central is the better. Then this we call it subarticular. Then we call it neural foramen, and this is the extraneural foramen region. So any protrusion in this area, I will say, suppose I make one protrusion. So here the base is more, height is less. So disc protrusion in the central region. If disc is here, suppose this is the protrusion again. So the disc protrusion in the right, we call it subarticular region, and this is the traversing nerve root. So suppose this is L4, L5 disc. So this is the L5 traversing nerve root, and this is the L4 exiting nerve root. I will show you one time more in the practical also. So as you see this, so this is, suppose this is L4 and this is L5. So this is the L4 exiting nerve root, and this is the L5 traversing nerve root. And this is the neural foramen. Sometimes neural foramen can be compressed by big osteophyte and all disc, which extrusion which goes in the neural foramen region that can compress the exiting nerve root. Okay, so there are some another problems that there is a study, and they done a study in MRI in an asymptomatic patient whose age was suppose 55 years. And they found in their study that patient is asymptomatic, but the patient has 4% extrusion, 4% patient has extrusion, 32% has protrusion, 64% had disc bulge, and 91% has disc degeneration. And patient is asymptomatic. So that means this disc protrusion, extrusion is maybe asymptomatic. So we have to know which is causing symptoms. So that is challenges. So there are some options of that. If there is a edema around that region, that means that patient is maybe the cause. Or in post-contrastive enhancement around that nerve roots, that is the cause. So sometimes contrast can help us in identifying the exact cause of the symptoms. This is the basically disc, and this is the annular fissure. Annular fissure can be radial, can be horizontal, can be like this. So we call it annular fissure, annular tear, and better to say annular fissure instead of annular tear. Annular fissure also, according to the literatures, may be symptomatic. This is described by Modic, and the end plate degeneration. So he described end plate degeneration 3 category, type 1, type 2, type 3. So type 1 is T1, will be dark on T1 and bright on T2. So sort of like edema. And type 2 will be bright on T1 and bright on T2, like sort of fat. And type 3 is dark. So type 2, type 3 is not a problem, but problem is type 1. Type 1 is, that means the end plate is dark on T1 and bright on T2. We can confuse with infection. So I will deal with this later on, maybe in my next slide. Yeah, okay. So this is the Modic type 1 changes where the end plate is dark. This is a T1, this is dark on T1 and is bright on T2. Okay, luckily here disc is dark. So this obviously cannot be infection, because for infection has to be, this should be edema, so bright. So at least there is no T2 bright. But in case you have T2 bright, then confusion happens. So we have another sequence in MRI, we call it diffusion. So in diffusion, if you do diffusion, then you can see in diffusion, then we call it claw sign. It will come like this, so sort of claw. So that can differentiate infection versus end plate degeneration. In some cases we are doing, not regularly. Okay, so we have talked about lumbar spine. Let us talk about spine, which is slightly different. In different means in the cervical spine, we have a lot of osteophyte. And sometimes osteophyte and disc we can't separate. So most of the radiologists, they use the word disc osteophyte complex. So like this case. So normally osteophytes is the peripheral part and disc will be central part. Even sometimes disc osteophyte also can be central, but most of the time the disc will be on the peripheral, and osteophyte will be, disc will be in the peripheral, disc will be in central, osteophyte peripheral. And sometimes we cannot separate, so we say disc osteophyte complex. So like in here, what we'll report is a disc osteophyte complex in the posterior, in the central and subarticular and neuroforamen region. So like this, you have to use one word, disc osteophyte complex. So the disc is better seen in T1. So we can see here, this is the disc and this is the osteophyte. This is the disc, this is the osteophyte. Here you can see this is the disc here. So there's a disc, sort of disc osteophyte compressing the spinal cord, and within the spinal cord there's some signal changes that we call it cervical myelopathy. If there's cervical myelopathy is there, when patient 100% have to be symptomatic and maybe some weakness. So this is the T2 abnormal bright signal within the spinal cord. This is the CT scan. The sometimes disc osteophyte complex better seen sometime in the CT scan. So you can see this calcified disc osteophyte complex in the subarticular region. Okay. 10 years back or maybe before, because my research was also on same topic. So we used to measure the central canal. And anything less than 10, we used to say absolute central canal stenosis. That thing has gone. Now, the new concept is that if there is a CSF between the nerve root, that is normal, even though it is 7 millimeter, not a problem. But if you have CSF and nerve root, that is normal. And if there is no CSF here, within the nerve roots are clumped together, that is central canal. This is the fact. This is the fact. So there is no CSF between the nerve root, central canal stenosis.
Syed, can I interrupt you for a second?
Yeah, sure.
Mind? Yeah. Syed, can you explain, because sometimes people may not be aware of the nerve root arrangement. I mean, those black spots, right? So those are nerve roots.
Right.
People are not aware. So maybe you can explain about that, and then.
Okay, excellent.
Because otherwise they wouldn't understand which is CSF, what is nerve root.
Okay. So, after the spinal cord end, which is that conus medullaris, these are the nerve roots. So normally nerve roots are arranged in very nice fashions like this. It should not come together. And what happened at, suppose again, I'll go at L4, L5. Okay. So this is suppose L4, L5 disc level. This is L4, L5 disc level. Okay. So here we can see there is one nerve root is here, which is traversing nerve root. And one nerve root is here, which is exiting nerve root. So at L4, L5, this is the L5 traversing nerve root, and this is L4 exiting nerve root. And these are all nerve roots within the thecal sac. And you can see this in the T2 weighted, we have to look for the CSF. So once there is this is the, maybe it's a little bit lower L, maybe L5. See the normally nerve roots are arranged like this in nice fashion. So once it's clumped together, no CSF, that's central canal stenosis. So for central canal stenosis, we have to see CSF within that thecal sac, or nerve in between the nerve roots. There should be CSF, the white spot in T2 weighted. If there is nothing like this case, so this is the disc, and these are the nerve roots, and this is the epidural fat. This is the epidural fat, and this is the ligamentum flavum. So see, the nerve root is clumped together. So this is central canal stenosis, and patient will have claudications. This is okay, this one?
Yeah, that's fine. That's fine. Go ahead, please.
So central canal stenosis, the definition has changed. We have to look for the CSF within the thecal sac. And sometimes there is some fat hypertrophy that can cause also we call it epidural apomatosis, can cause central canal stenosis. Okay, now we'll have some how to report this case. Okay, so first numbering. So this is the L4, this is L5. Sorry, so this is L5, this is S1, and this is L4. This is L4. Okay, so you can see there's a disc which is extending like this, and it is basically what happened. This is the end plate. So it is crossing the end plate. So by definition, this is extrusion. Okay, so this is extrusion in the left. So what I told you, this was the central, and this is the central area. Then this is the subarticular area. So here the disc is in the central and left subarticular area. And this was the right traversing nerve root, and basically left traversing nerve root is compressed. And this is the exiting nerve root here, I think so. So I will write like this: a disc extrusion in the left subarticular and central region, compressing and displacing the left L5 traversing nerve root. So this is the good explanation of the then I will say the exiting nerve root is normal. I will see also in the sagittal cat, but this is the way we should report. We should comment upon some facet. Then you can see here, these are the nerve roots, other nerve roots, and there is a CSF in between. So those are no central canal stenosis. This is the ligamentum flavum. So this is the facet joint. So this is the disc extrusion. We have another way. Okay. So again, this is the end plate, and this disc is crossing the end plate. So by definition, this is disc extrusion. So I will say a large disc extrusion in the central and subarticular region, more towards the right side, compressing the traversing nerve root more severe on the right side. Correct? So this is the exiting nerve root. Traversing nerve is totally compressed here. And here maybe this is the traversing nerve is compressed, but this side totally compressed. So I will say this is again L4, L5. This is L4. So I will say again, say disc extrusion because it's crossed the end plate. In the central and subarticular region, more on the right side, compressing and displacing the traversing nerve root more severe on the right side. The exiting nerve root are normal. Yeah.
Yeah, Syed, can you mark out the extruded disc on the axial image?
Okay. Okay. Very good. Excellent. Okay.
Because axial is what people find it very difficult to interpret.
So basically, these all are extruded disc. And this is the thecal sac here. This is the thecal sac here. And this is the epidural fat here remaining. So this is the
posterior vertebral margin.
Okay. So this is the ligamentum flavum, and this is the epidural fat here. So this is the epidural fat. This is the thecal sac remaining. So tight central canal. Although we have one dot, this one, but a very large disc extrusion. We should not go here. Don't think that this is base more than height because it is cross already the end plate. Once cross the end plate, this disc extrusion.
Okay, great. Thank you.
Again, once more, I keep so many so that there will be no confusion. So again, it's L4, L5. So you can see there's a disc. Again, you can check it is crossing the end plate. So disc extrusion. Other definition also here, the height is more than the base. So by both definition, this is disc extrusion. Then what happened? This is again central and subarticular region and compressing these are the traversing nerve root, more on the right side, almost like same. So, okay. So how we know? So there is a grading system about this displacement. So sometime that will be, the disc will be, okay. So suppose this is the disc, this extrusion, okay. And sometimes maybe suppose there's a very small disc extrusion, which is just touching it. So we say just abutting the disc. That is the grade 1. Grade 2 is compressing. That means shape of the nerve root will change. So normal nerve root is a little bit round. So that will be flat or a little bit edematous. So that is a compressed. Then another grading is that, so nerve root, there's a place. So we have to go somewhere. Okay. Okay. So just suppose this is the nerve root. This is the place of nerve root. So when disc will come, this will displace the nerve root to more backside. So that's a grade 3, compression and displacement. So here, this is the exiting nerve root. This is the traversing nerve root, which is compressed. This is the traversing nerve root, is maybe not very much compressed, but right side is compressed. This is the thecal sac. And this is a small epidural space, epidural fat. This is quite interesting case, as I told you before. So you can see if you go by the Meyerding's method, so draw a line from here, 90 degree, another 90 degree to it. So L4 is crossing this line. So this is spondylolisthesis, grade 1. Then see, the pars is totally abnormal. There is a fluid in the pars, fluid in the facet joint. So this is degenerative spondylolisthesis. So this fluid should not be there. And also facet angulation. Normally, if you draw a line from the vertebral end plate, this surface, the facet joint should be 45 degree. This angle should be 45 degree. But here the angle is changed. That we call it facet syndrome. These things are in the earlier literature. But obviously this facet is totally abnormal. So this is, we call it degenerative spondylolisthesis. So why it is important? Because if I will not mention this degenerative spondylolisthesis, surgeon might goes and just remove the disc and he will not do the posterior fusion. So patient symptom will not improve because the instability is there. So has to fix the instability plus disc, both. So that's why it's very important to see the facet fluid and facet joint instability. The X-ray is better. We do flexion extension. Such cases, basically, X-ray should be done for in the dynamic X-ray, flexion extension. If there is instability, have to fix that also. That is very important. Otherwise, patient might not improve. Another thing is that we should also know that sometime because of the extension exercise, disc may go up. So this patient has large disc. Disc acute sum can be a little bit intermediate signal. So this is the disc extrusion, which after 8 months resolved, almost resolved. So this is also known in the literature. We have 50 cases researched where disc resolution is there in 1 year of time. Because I am putting these cases more because this is very important. So this is we call it pars interarticularis. So there is a defect in the pars interarticularis. We call it pars defect, spondylolysis. There is a forward displacement of L5 over S1, and also there is some degenerative changes. This air in the disc, we call it Nutsel sign or vacuum sign of degeneration, and there's some sclerosis. This is we call it perineural cyst or Tarlov cyst. So I think this degeneration is enough. I think most of us we have understand now. So we'll go to the next topic, which is infection. So this is the plain X-ray. Patient is symptomatic, but plain X-ray may be normal. So somebody has leukocytosis symptoms. So we should go further. So this patient has done CT scan where there is destruction of the end plate and disc both at C3, C4, and post contrast shows some enhancement in the CT scan. So MRI done. MRI also same thing. Lot of epidural collection here. This post contrast of phlegmon sort of thing with small abscess in the prevertebral region also. So this is spondylodiscitis. So how to differentiate spondylodiscitis? So in spondylodiscitis, there is the end plate destruction, the disc destruction, and there are some epidural abscess and patient condition will be acute. So here there also you can see the NT1. This is the normal marrow, but this marrow is dark. So whenever marrow is dark, localized with leukocytosis, with symptoms of fever, we should think of spondylodiscitis. Then we have very common in our country. So that's also we have to know. So if one patient has more than one vertebral body, 2-3 segments are there, and here what happened? The disc is not destroyed. The end plate will be destroyed. End plate will be destroyed, but disc will be maintained. Okay, and the lot of paravertebral abscess. So this patient had a lot of psoas abscess, lot of psoas abscess, and patient may be not very much symptomatic, not toxic, and history of 5 months, 6 months will give. So this is tuberculosis. So there is an end plate destruction. The disc is a little bit still maintained. A lot of paravertebral and psoas muscle abscess, and maybe more than 2 vertebral body involved. So that we think of TB. And in the abscess, you might find some calcification. So these are features of TB. Let's say, look here, the end plate is destroyed. Okay, here disc is destroyed, but see the end plate totally gone. And there's some calcification. So this is tuberculosis. Again, here, see the end plate is a little bit maintained, and it crossed the more than 2 vertebral body, more than 1, 2, 3 vertebral body, epidural abscess. So these are tuberculosis. And here's here. So here disc is basically abnormal. And so this is bacterial or spondylodiscitis, not the tuberculosis, because the disc is involved far earlier than the end plate.
Syed, if I can interpret for
a
second.
Sure.
Yeah. So how do you differentiate it from a malignancy? So that is what the most common differential.
So, okay, right? Again, very good question. So in malignancy, normally disc will normal. So in TB infection, disc will slightly abnormal. In malignancy, disc will be normal. So if disc is normal, think of bad thing. So this is so that's very good sign basically.
So if the disc is destroyed, it means we are safe.
Yeah. Yes, correct. Okay, so I just put intentionally so that you should know that what is this? This is not infection. So here what happened, there is a very well-defined edema. So whenever edema is very well-defined, this is nothing but Schmuller nodes, acute Schmuller nodes. A disc is maintained, a disc is normal, and there is some signal which is quite well-defined, and edema is also well-defined, smaller nodes. Another case, there is a edema which is very well-defined, smaller nodes. So very easy to distinguish. So now our third topic comes, which is also very important, because sometimes we'll get some collapse and then patient will ask, I have what I have. So we have some features. So this also I will show you some cases. So there is a collapse of the vertebral body. First, go to T1. So I told you my spine rule number 1. The vertebral body is darker than the disc. So this is abnormal. Okay. Then one vertebral body is collapsed, and you see the end plate, the posterior margin, it is convex. And this is basically T2, this is abnormal. So this is multiple myeloma. So what happened whenever we found we get an abnormal marrow signal with a posterior vertebral margin which is like convex, that is a malignant. So how to differentiate malignant and benign? Okay, so this is the answer. So again here, so this is the T1. So you can see the vertebral body is totally darker than the disc. So it's abnormal. Little bit of there are some remaining 1 or 2 yellow marrow, but most of them are dark. This is the T2, again, very heterogeneous marrow. Post-contrast heterogeneous enhancement, and this is multiple myeloma, severe multiple myeloma, diffuse multiple myeloma. I will just coming back to again how to differentiate after this case, because if you report MRI, everybody will get this, and sometimes they worry about this. So in T1, there's a bright. So you can see the fat is bright. So that means this lesion has a fat. Most of them are, we call it Lipo Hemangioma. So Lipo Hemangioma are 2 components, lipid component and hemangioma vessels vascular component. So when vascular component is more, little bit, that can be little bit bright on still stere, but see central is dark. This is also hemangioma. So any lesion which is bright on T1, suppressed on stere, that is a typical Lipo Hemangioma, more lipid hemangioma. So this is very important. Anytime you have some difficulty, then just do CT scan. On CT scan, you will find, we call it corti sign or polka dot, are very diagnostic of the hemangioma, which is much better than the do biopsy. So sometime if there is a diffuse aggressive hemangioma, something like that, we just do CT scan. We follow corti sign or polka dot sign. So this is like corti sign, and you can find some of the polka dot sign. This you will find like dot like this. This is one of them is this dot. So like polka dot sign. Okay, we're coming back to again osteoporotic compression fracture versus malignant versus benign. So in the benign part, so this is the collapse of the vertebral body, about 50% vertebral body height is reduced. And this is the T2, this is the T1. And you can see one of the part of the end plate where this marrow is normal. So with a band of the marrow is normal. So this is the benign. And you can see the posterior margin is flat. Again, I will show you. So this is, multiple compression fracture. This is T2 weighted image. This is sort of fluid within the vertebral body. This is osteonecrosis within the body. So this is a case of osteoporotic compression fracture, and air or fluid within the vertebral body, sign of necrosis, that we call it Kumel disease. I think we have one. Okay, this Kumel disease. So Kumel disease is basically osteoporotic benign fracture, osteoporotic compression fracture with osteonecrosis. This is not a serious issue. So you can see within the vertebral body there is air. So this is an osteonecrosis. So this is osteoporotic compression fracture. We call it Kumel disease.
Syed, can I interrupt if you don't mind?
Yeah, sure.
The previous slide, when you said air, it's at the black shadow, right? When you say Kumel's disease.
Yeah. So, okay, Kumel disease, okay, osteonecrosis.
Yeah, this is the black shadow there.
Osteonecrosis has 2 findings. See, either air will be within the vertebral body. See, disc air is a degeneration, not a problem at all. We call it Nutzel sign. But within the vertebral body where there is a fracture happened, so when after fracture happened, that area, necrosis will happen. So either fluid accumulate or air accumulate. It will convert to necrosis and air. So that also not a, like, don't think of that air. This is benign air. This is not a problem. So we call it osteoporotic compression fracture with osteonecrosis. Other name is Tumorous disease. So this is see like this.
This is the black shadow, right? In the bottom slide, the black shadow. That is the one that shows air.
Yeah, air within the vertebral body.
Okay, got it.
Yeah, and can be fluid, can be air within the vertebral at the site of fracture. That is a sign of osteonecrosis. So Tumorous disease. Okay, so now we'll go back to here. Okay, so this is my rule number 2. If there is if the collapsed vertebral body with angulated posterior margin is a benign. If the margin is convex, it is malignant. If the vertebral body has maintained a band like end plate, normal marrow, that is a benign. If it is a round, something like that, it is a malignant. Then I will show you some cases. So like this case, here the vertebra is totally collapsed and you can see the posterior margin is angulated. So this is benign. This is osteoporotic compression fracture. Here also there is angulated. Okay. Here we can see there is a band of yellow normal marrow is maintained, and see the margin is smooth, continuous. So this is osteoporotic compression fracture. Again, here the margin is angulated, so this is benign. Here margin is convex or malignant. Again, here the margin is angulated with a fracture. This is benign osteoporotic fracture. And see angulated, so this is benign osteoporotic compression fracture. You can see even the fracture lines are there here, multiple fracture lines. So these are osteoporotic compression fracture. And here, first the marrow is abnormal, diffuse abnormal marrow, and margin is convex. So this is malignant.
So in a benign fracture, it either can be straight or it can be angulated, right?
Angulated, correct.
Two options for a benign.
Yeah. And most of them, they will have a band of normal marrow signal like this. Band, total band.
Got it.
They will have a marrow signal. Okay, so there are sometimes you are doing MRI, you will find cyst. So this cyst is in the region of disc. We call it disc cyst. Sometimes you will find cyst here, which is very common. That is a facet cyst. And sometimes this facet cyst just can go protrude within the thecal sac. So sometimes the orthopedic surgeon, they go by here by facet joint and they push water and they make it burst. Patient improve. So this is for the synovial cyst. This cyst, this is a disc degenerative cyst. So these cysts, facet cysts are very common. Sometimes inside, sometimes they are outside. Quite common, very common.
Syed, one more term is an intramedullary and extramedullary.
That will be basically used in the tumor normally in tumor respect.
Do we have a slide?
No, tumor. Okay, no problem. This is also important. What happened most of the time, sometimes these are the cases which went to orthopedics doctor, and you will find that patient will have the same low back pain, if CRP will be high, and you can see this is T1, this is T2, and you can see at the corner there is a bright. So we call it shiny corner sign, and should be more than 4 vertebra, because shiny corner sign is also seen in degenerative, but normally 1 or 2 vertebra. If you find more than 4 vertebra dorsal region, this is specific for the spinal arthropathy. So this is called it shiny corner sign. Sometimes same entity will be there in the end plate. That we call it Anderson lesion. Here we don't have. So there will be same abnormal bright signal in the end plate area, in the posterior end plate, this area we call Anderson lesion. And if you go parasagittal, you will find a lot of enthesitis in the posterior part, lot of edema in the cervicovertebral junction, these things, a lot of inflammation. So these are spondyloarthropathy. This patient will have also abnormal sacroiliac joint, sacroiliitis. So if, again, I will tell you, there are more than 4 vertebral body shiny corner sign, then there will be Anderson lesion. Then if you go to parasagittal, a lot of enthesitis will be there, and patient will have bilateral sacroiliitis. Like here also there's a lot of inflammation in the interspinous ligament. So this is spondyloarthropathy SPA. So that is a little bit of in rheumatology causes.
And Syed, how to differentiate between an Anderson lesion and a tuberculosis?
Okay, that's a good question. So, TB, in the TB, as I said, that it will be the end plate involved, disc will be maintained. So maybe you confuse with Anderson, but most of TB, there will be some psoas, paravertebral abscess, because TB involve the end plate, then it go to paravertebral area. So that is a very diagnostic of the TB. That is feature of TB. Otherwise, may be difficult. So epidural space collections, these things are.
So we just remind the viewer that Anderson lesion is seen in inflammatory arthropathy, like ankylosing spondylitis or any of those spondyloarthropathies. Am I right?
Yes, correct.
Yeah, I'm just want to reinforce them because you have not written Anderson lesion. I just want to tell the viewer.
Yeah. I mean, in fact, this is a little bit of Anderson lesion here.
And there is one more sign called as Romanus sign. I'm not sure.
That is the shiny corner sign, same. Shiny corner, Romanus sign, same thing.
Okay, so we have both. We have explained both. Shiny corner sign is the Romanus sign, and the other one is Anderson.
This is little bit Anderson type of lesion because it went to half of the vertebral body.
Okay, great.
Okay, these are rare cases where you'll find vessels in the surface of the spinal cord. This is dural fistula. Rare cases, not common. I have seen only one. This is quite common nowadays, very common. I am seeing this every 2 months, one case. And most of they are basically, sometimes radiologists are making diagnosis metastasis. So what are the findings? See, sometimes the vertebral body will become very enlarged.
Picture frame
Very enlarged, like iliac bone become very thick, then sclerotic. And if you do alkaline phosphatase, it will high. So this is Paget's disease. Very common nowadays, very common. At least 5-6 per year where I'm seeing the cases. Suddenly increase. In the West, it is decreased. In this area, it is increasing. Okay, this I intentionally I put because what happened most of the time, people, they think of discitis. So if fluid in the T2 bright in the disc is not discitis. Why? Because see the end plate is maintained. So this is just degenerative changes that can also cause disc bright signal. So this is not infection. Okay, this patient has mild spondylolisthesis. That's the cause of degenerative changes. Then it's very common. Most of the patients will have a small perineural cyst or we call it Tarlov cyst. Very common. 99% are asymptomatic. Some are, according to the teachers, few are symptomatic. This I post intentionally post-op spine, because in post-op spine, when we give contrast, it enhances. So we should not think of infection. So what we should know that how the surgeon has operated. Suppose surgeon has operated on the right side. So that will be post-contrast enhancement. If there is enhancement in the, suppose this area in the psoas region or where there is a not track, that is an infection. So if we have to know the track of the surgery, and in that area, if it is enhancement, this is a normal post-op changes, which is not infection. So again, same thing. So here this track is on the right side. So these changes are post-op changes, not infection. There's a normal finding in post-op conditions. And here also I put this thing. So normally we are giving sometime recurrent disc versus scar tissue differentiation. So we should do our MRI within 10 minutes. That means the scar will enhance and disc will not enhance. But if you delay, then both will enhance. Then it will be problem. So that's why you have to tell technologists. So we have to finish MRI within 10 minutes. And I think this is one of the last slide. Here you can see the marrow is a little bit dark. This is total bright. So this is post-radiation changes. This is the hair normal. This is the abnormal. This is fatty replacement of the marrow because of post-radiation. Okay, we have one or two slides more. This is a very painful condition where there is a calcification, or we call it crystals, in the longus colli muscle. This is calcific tendinopathy, tendinitis. Very painful condition. So CT is, because calcification will pick up by CT scan, not by the MRI. That's why CT is better sometimes, not sometimes, many times. And there's another condition where there's a calcification of the posterior longitudinal ligament. We call it OPLL, ossification of the posterior longitudinal ligament. This I also have two cases with me. So here you can see the spinal cord going like that. Then here there's a depression that we call it scalpel sign. That is feature of dorsal arachnoid web. So this scalpel sign is a feature of arachnoid web. And if there is a total herniation, arachnoid cord herniation will be like this concave defect, like this. So like this. So if the spinal cord goes and bulges like this, herniate, this is the cord herniation cord. And if there is a defect like this, we call it scalpel sign. This is so scalpel sign is the arachnoid web, and there is a bulge like this. This is the cord herniation. This is also easy, not a difficult.
Now, is spinal cord herniation symptomatic?
That I don't know.
Okay. Now, do you see it very commonly? That's
I have seen this two with me.
Okay. Because normally the herniation is the other way, right? You have the disc herniating into the spinal cord. Now the spinal cord herniating into the vertebral body.
I have two dorsal arachnoid web with me. Two.
Okay, great.
And this again I put intentionally because this is one of the young people. When the young people, they do MRI where there's no disc. And pain is because of the facet defect, pars defect. So we should catch that. That is very important because patient has pain, and so nowadays MRI everybody can afford. So they go inside, and sometime if we are busy and not go and particularly look this, we'll set normal report. But patient has pars defect and the cause of pain. So that's why I put this one. And okay, these are also, we have ward patients, old patients, and sometimes post dialysis, a lot of erosions of the end plate. But this typical dialysis or spondyloarthropathy, dialysis, post dialysis, and arthropathy changes. Those who have renal failure for 10 years, 15 years on dialysis, they will develop this amyloidosis and like this. In the MRI, you'll find a lot of dark signal here. These are all amyloid depositions.
Syed, can you take to the previous slide? Yeah, I see. I just want to read out a question that the cervical spine.
Yeah.
See, someone wants to know, how does a cervical spine myelomalacia appear? That's in our YouTube chat box. So you can just mention it on this.
Oh, no, I will show. I have one myelomalacia. So this is basically spinal cord. Okay, so what should we know? There is one entity, we call it spinal atrophy. Okay, spinal cord atrophy. So when I think there is a thickness which I mentioned, I forget that one. I think 50% reduce in thickness atrophy, and that is a cervical atrophy. There are thickness more than, I think I forget the diameter. And when there's a T2 bilateral, we call cervical myelopathy. Cervical myelomalacia atrophy, that is some thickness I don't remember that one.
And also you'll have both signal changes, right? The radio opaque as well as radiolucent. That is how you say it's a cervical myelomalacia, isn't it?
This term I will check. Myelomalacia. Normally MSK is not, we are using that term.
Okay, and the other one, one more question by one Dr. Pratipati Rambabu is how to decide which disc bulge is causing symptom if there are multiple disc bulges?
Let me finish. We have 3 slides.
Okay, fine. Okay, great.
We have 3 slides and we could take questions. This also very important. What happened? So, you know,
keep it full screen.
Oh, sorry. The three remaining, which is very nice, interesting cases. So this is the neural spine, and in between the neural. So this is the neural spine, and in between neural spine there is a fluid or edema. So this is, we call it basically interspinous bursitis or Bastard disease. So those patients who has lumbar lordosis, they develop this Bastard disease or interspinous bursitis. And I think this is already I've shown you. This is the epidural fat. So this is central canal stenosis because of epidural lipomatosis. And you know, this, there are, as I told you before, this patient has multiple Schmoller nodes, multiple with end plate irregularity. That is Schmoller disease or adult kyphosis. Your question is what? Can you tell me the question?
Yeah, how to decide which disc bulge is causing the symptom when there is multi-level disc bulge?
Yeah, so basically here the importance of clinical care. So we say don't treat MRI, treat the patient. So you have to say patient which segment has a pain. So you know better than me, L4, L5, you have to examine the patients. So that is the importance. And if you want, then what happens if you sometimes confusion, then we inject contrast. So AC nerve root enhancement. If nerve root enhancement is a sign of abnormality, so these are the way. Now the nerve root will be thick, enhance. These are the sometimes helpful. Otherwise, it is a very difficult question.
And how to diagnose a dry TB on MRI?
What?
How to diagnose a dry TB?
No idea.
Okay, no worries. Anyways, thank you, Syed. Brilliant presentation as usual, and wonderful cases. And I'm sure we could do one more presentation later on.
Thanks. Thank you. Thanks for